Hi everyone, and welcome to the video. Today we're diving into medication questions designed to help you build a strong foundation in emergency nursing essentials. So these questions are based on the medication review video we recently posted. So if you haven't watched it yet, I recommend checking it out for a quick refresher. Again, thank you for watching. So let's get started. For the first question, for a patient getting intubated, both etominate and succinylcholine are ordered. Which medication should be given first? So in rapid sequence intubation, the sedative is going to be administered first to ensure the patient is sedated and does not experience the distress of being paralyzed and intubated. Now, for the next question. What is a key complication to monitor for when administering succinylcholine during RSI? It's going to be hyperkalemia. So we know that succinylcholine can cause a significant release of potassium from cells into the bloodstream, leading to hyperkalemia. And as you know, that can be very life-threatening. So we avoid sucks with patients who are at risk for this, including patients that are in renal failure, patients with burns, crush injuries, or even rhabdomyolysis. Next, how long does rocuronium typically last when used as a paralytic in rapid sequence intubation? It's going to be 60 minutes. So rocuronium has a duration between 30 to 60 minutes, which is significantly longer than succinylcholine. As we discussed in the previous video, we like to use sucks when it's not contraindicated because it's very short, has a very short duration, and in case anything goes wrong, such as a failed intubation, sucks will wear off and we can manage the patient. But rocuronium, even though it doesn't come with that contraindication of hyperkalemia, does last longer. So if there is a failed intubation attempt, you need to be prepared to manage that as well. So for the next question, why is it important to check blood pressure every 5 minutes after starting a propofol infusion on your patients? Specifically after they got intubated, right? They're going to be started on a propofol infusion. Why do you need to check the blood pressure every 5 minutes? Well, we need to monitor for hypotension because it's a very common side effect of propofol. We know that propofol often causes hypotension due to its vasodilatory effects. So frequent blood pressure monitoring ensures the patient remains hemodynamically stable and that you keep a very close eye on it. And if they do become hypotensive, you can do something about it. So why is Versed or midazolam often chosen as a sedative infusion for hemodynamically unstable patients instead of propofol? Well, Versed has a less pronounced effect on blood pressure compared to propofol. So Versed is often chosen when propofol causes hypotension because Versed has less pronounced effects on blood pressure. While Versed may still lower the BP at high doses, it's generally better tolerated in regards to blood pressure compared to propofol. Next, in which condition is a nitroglycerin infusion most commonly used to reduce preload and afterload, easing strain on the heart? It's going to be congestive heart failure. Nitroglycerin is commonly used in CHF exacerbations to reduce preload and afterload, easing the strain on the heart and improving symptoms by lowering pulmonary pressures. By the way, if you're finding this helpful and want a deeper dive into what it takes to thrive as a new ER nurse, check out our book or course. They are packed with practical tips and everything you need to feel confident and prepared in the ER. You can also join the channel as a member and gain access to the course as well. You can find the links for the book and the course in the description or in a pinned comment, or simply click on the join button and become a member. So for the next question, why should nitroglycerin be avoided in patients with a right-sided myocardial infarction? So nitroglycerin reduces preload, potentially causing severe hypotension. In right-sided myocardial infarctions, the right ventricle is preload dependent for maintaining cardiac output. So since nitroglycerin reduces preload, and the right side is preload dependent, this can lead to severe hypotension and compromised perfusion more deeply. For the next question, what is the typical starting dose for a nicardipine cardine drip in the management of an intracranial hemorrhage? The typical starting dose will be 5 milligrams per hour. So when you have an intracranial hemorrhage patient and they are very hypertensive, you know that that's going to worsen the bleed, right? So they're often going to be started on an infusion of a medication to bring that blood pressure down. Typically, it's going to be nicardipine. You start it at 5 milligrams per hour. Your facility's protocols may be a little different, but most facilities will have a range of 5 to 15 milligrams per hour, with the 15 being your max. You start it at 5 per hour. You titrate by 2.5 milligrams every 5 minutes up until you get to the 15, or up until you have an adequate decrease in the blood pressure to a desired goal. The desired goal for these intracranial hemorrhage patients, as far as their blood pressure, is typically less than 140 or around a systolic of 140. So next, why is it important to check the heart rate before administering a labetalol push for a hypertensive emergency? So labetalol slows the heart rate, and giving it in bradycardia will lead to complications. So it does have those effects on the blood pressure, but we need to be aware of the heart rate as well. Because let's say they're super hypertensive and the heart rate's in the 40s and you just didn't check it, and you give labetalol, you're going to worsen the bradycardia. You're going to ultimately cause them to go into hypotension and even into shock at some point. So when you're going to give a labetalol push, don't just look at the blood pressure. I know that's why you're giving it, but also look at the heart rate. If they order the labetalol, the heart rate's anywhere less than 60, you have to tell your provider, hey, the heart rate's less than 60. Let's give a different medication, okay? The next question, which medication is commonly used in the ER to treat atrial fibrillation with a rapid ventricular response? So typically in the ER, we're going to be using cardizem. It's a calcium channel blocker, and it's often going to be the first line medication used to treat AFib RVR. There's also metoprolol as well, and that can be used if the patient has certain comorbidities, but the go-to medication is going to be cardizem. Next, what is the typical infusion protocol for an amiodarone drip in the management of arrhythmias? It's 150 milligrams over 10 minutes, followed by 1 milligram per minute for 6 hours. Then, after the 6 hours pass, 0.5 milligrams per minute for 18 hours, turning out to be a 24-hour infusion protocol if the patient can tolerate it. Now, when administering TNK, tenecteplase, for an ischemic stroke, what is the maximum time window from symptom onset in which it can be administered? It's going to be 4.5 hours. So we're giving it for an ischemic stroke, and timely administration is going to be critical to maximize its effectiveness in dissolving clots and minimizing brain damage. So, next question, which vasopressor is considered the first line treatment for septic shock after adequate fluid resuscitation? It's going to be norepinephrine. We use norepinephrine because it effectively increases blood pressure through vasoconstriction, and it has a little bit of an impact on the heart rate and contractility. Can norepinephrine be administered peripherally in an emergency situation? The answer is yes, but you should only do a short term and through a large bore IV until you wait for a central line to be placed. You should only do it temporarily, as prolonged peripheral use increases the risk of extravasation and tissue damage as well. And for the final question, why is it essential to closely monitor a patient after administering a B52 combination or other sedative medications? Well, because when you combine medications, you run the risk of oversedation and respiratory depression. So after you give these medications, especially if your patient was very combative and you start noticing that they're getting sedated, place them on the monitor as soon as you can and keep a very close eye on the vital signs, on their oxygen saturation, just to monitor for respiratory depression and over sedation.